Okay, well, welcome everyone. Hello, and thank you for your interest and participation in our new webinar series on innovation and progress. In order to reserve time for the important presenters and information we have today, I wanted to draw your attention to a link that will be coming in the chat that will include the presenters' bios today, as well as our slides. My name is Amy Goldstein, and I'm the director of the Alliance to Advance Comprehensive Integrative Pain Management, or AACIPM. I'll be co-moderating today with Dr. Robert Kearns from Yale University, who's the director of NIH DoD VHA Pain Management Collaboratory. So I'm looking forward to this session. And with our esteemed panelists who are representing a range of perspectives from people with pain, payers, purchasers of healthcare, healthcare providers, academia, researchers. And these panelists are Kate Nicholson from the National Pain Advocacy Center, Denise Giambalvo from Washington Health Alliance, David Elton from Optum Labs, Daniel Blaney Cohen from American Medical Association, and Ben Kligler from the Veterans Health Administration. I'd like to begin with a big thank you to the David and Laura Lovell Foundation, who are the primary sponsor for the AACIPM initiative. And a special thanks to the fiscal sponsor for this project, the Pain Community. And just for some level setting, want to share AACIPM is not an organization. It is a NIMBLE grant-funded initiative born from past advocacy efforts of the American Academy of Pain Management, which was later called the Academy of Integrative Pain Management before it closed after 30 years. AACIPM is a multi-stakeholder collaborative. Our stakeholders include people with pain, payers, purchasers, healthcare providers, academia, government agencies, advocates, and more. And some of our outputs include communication, policy advocacy, education and awareness, and coordinated responses. Our main focus is to connect the dots to advance equitable, whole person, multimodal pain care. And why are we needed? Why is this important? Well, AACIPM understands that chronic pain is the #1 cause of disability globally, and this will be discussed in different ways with other presenters. We know how to treat pain well, and yet there are many challenges and barriers that keep this from happening and from people being able to access quality care. This is a visual of a new toolbox we've created to help draw awareness and bring attention to the toolbox for whole person-centered pain management, or comprehensive integrative pain management. This is a little easier to see. This next view, I know will be difficult to see on slides, but you can see on our website, this can be downloaded as a PDF, or it's also on a web page at painmanagementalliance.org/what-is-CIPM. But what I want to draw your attention to is the important factors, the social determinants of health, biopsychosocial factors that have such an integral role in a person's ability to access quality care. And there are challenges that keep people from this access that we'll be talking about throughout our time together. And these include misperceptions and stigma, people with pain, lack of awareness and education, business case data disagreement, workforce supply and demand, misaligned financial incentives, and integration and cultural incompatibilities. You'll hear more about all of this. I want to just spend a couple minutes on sharing a few examples of AACIPM's recent work that has relevance to our session today. So one is we just released this past Friday a new brief on pediatric pain in order to build awareness for this underserved population across our stakeholders. And I think would be difficult for anyone to not agree that young people are just in great need of a comprehensive integrative approach to pain management. And it is so often something that is difficult to achieve. And adverse childhood experiences are growing, and they often result in negative health effects in later life, including a much greater risk of developing chronic pain. I will note that, again, with the inclusivity of how this alliance works, we are requesting action from anyone who is interested in reading this brief. We would love to have your review, feedback, and any suggestions for expert presenters for a future webinar on the topic. And a couple quick examples of work related to our collective responses to HHS. So we were excited to see that CMS took some of our recommendations that we had shared in a collective letter regarding bundled payments for integrative pain management. We continue to work on this issue and bring together stakeholders and welcome any feedback in that area. Also wanted to point out, we submitted collective responses to AHRQ, the Agency on Healthcare Research Quality, on integrated pain management program systematic review. And I'd like to quickly just read an excerpt from this because it will be touched upon later today. So this is about the CDC pain management guidelines. 3 years after its initial release, the CDC recognized the chaos and harm it inadvertently created with its guideline and released a statement advising against the misapplication of their guideline and offering further clarifications. A year later, CDC established a new opioid work group and plans to complete updates to their guideline by the end of 2021. Because despite the best intentions, they have seen barriers and challenges in implementing the guideline strategies. Unfortunately, some policies and practices derived from the guideline have been inconsistent with and often go beyond its recommendations. It is our hope that AHRQ will not add to the body of confusing and low quality evidence, but rather will set a new standard for basing findings upon high quality evidence, or at the very least being explicitly clear when making a statement based upon low quality evidence. And you can read the whole letter at this link shared on this webpage, and others may have different opinions of this. And I will just say we welcome that. And now I will move to the format for today, which you'll hear from the other individual presenters, and then we'll move into a Q&A discussion. Please feel free to submit any questions you have through the feature, and then we'll close closing remarks at the end. We do, in the spirit of connecting the dots, intend for this session to be provocative, to spark ideas, discussion, and potential action steps to increase integration of equitable, complementary, integrative, and behavioral health approaches for the millions of people in need of quality pain care. And so please share your engagement using the hashtag AACIPM, follow us on Twitter or LinkedIn. And without further ado, I would like to introduce our next presenter, Dr. Robert Kearns.
Good morning, everybody. I'm delighted to have been invited to help moderate this wonderful event. So thank you very much to Amy and those involved in organizing this. Next slide. I'm going to be really trying to frame my remarks as kind of introductory and really building on what Amy, somewhat redundant with what Amy just described as the overall kind of objective or raison d'etre for this organization. I'm going to also specifically comment on a major tri-government agency investment in this area around building capacity for integrated models of care that specifically incorporate non-pharmacological approaches for the management of pain and co-occurring conditions, particularly in military and veteran health systems. But I hope that you'll see this as broadly applicable much beyond those two integrated systems. Next slide. I like to frame almost every talk that I give in the context of the IOM report that Amy was highlighting back from 2011 that really had a primary recommendations for the development of a comprehensive national strategy for promoting pain management that ultimately was published by the Department of Health and Human Services called the National Pain Strategy. I was privileged to be involved in both of those groups. And particularly, I was one of the co-chairs for the service delivery and payment chapter of the National Pain Strategy. Next slide. This strategy really provided a framework that helped us understand really what Amy has already emphasized, the many challenges that exist to delivering quality of care more generally, which is often not based on the evidence, is not team-based, and is limited to pharmacologic treatment offered by a single practitioner with limited access to procedure-oriented or specialized, highly incentivized specialty care. So we need more quality research on the effectiveness of a broader array of interventions, but particularly models of care and reimbursement innovations. And we need strategies for bringing our positive findings and products from our research to bear on changes in our actual policy and practice initiatives, and importantly, clinical care at the point of contact with people with pain broadly, chronic pain more specifically. And we need to address these, I think Amy's language was polite, I'll call perverse incentives for the way things are managed now. Next slide. There are many different models of care. The VA and DoD have adopted a step care model of pain management that's viewed as a population health and evidence-based model of care, but there are many others, and you see them listed here. The bottom line is we need more research on all of these models to help us just make decisions, both, maybe within large integrated health systems like the VA, DoD, maybe others like Kaiser or Geisinger, but also really how do we bring any of these models to care to fill the gap in our routine practice in really the rest of the country, at least in the US. Next slide. I was involved as a proponent of one major evidence synthesis review that did focus somewhat on VA and DoD studies, but it turns out that's where some of the best research has been. This review was published, but I really want to highlight the puzzle piece that says we need to, that highlighted from this review kind of the core components of an effective model of care, including need for more decision support at the point of care that includes provider education and training, improved patient education and activation. Really, I would extend that to the public, broadly speaking. We need to focus on increasing access to multimodal care. But to the extent that we do that, it's important to acknowledge that more care isn't necessarily better care. The issue is about care coordination and integration that Amy has already highlighted. Next slide. So there are many barriers. Amy's already highlighted these. This is just a relabeling of some of the barriers that are already represented on the website for this organization. I'd say it's important to acknowledge that they cut across really the broader domains of the public and patients to providers and the clinical care settings to organizational barriers and even, of course, payment and reimbursement barriers. Next slide. So broadly, I think we can acknowledge there's a gap between what we think we need to be doing and what we are actually doing. And I would suggest that pragmatic clinical trials, which are at the end of the continuum in the direction of dissemination and implementation, kind of moving away from efficacy or explanatory trials, are important in addressing this gap, and thus this major investment. Next slide. So the NIH partnered with the DoD and VA in 2017 to put out a call for proposals for a coordinating center, and then separately funded pragmatic clinical trials, again, of models of care or non-pharmacologic approaches for management of pain and co-occurring conditions in veteran or military health systems. This was initial $81 million investment. We've already received supplements to support this. It's about supporting the trials and their successful completion, but learning about this whole entire enterprise of pragmatic studies and how to improve their generalizability and as well as their scientific rigor. Next slide. So there are actually now 12 separately funded pragmatic trials as part of this collaboratory. These are funded by either NIH, particularly National Center for Complementary and Integrative Health, or the DoD or VA, Health Services Research and Development Service. You see the titles and the PIs and the funding source here. I'd point out that about half the projects really focus on models of care, including the most recent one on a telecollaborative outreach program for rural patients. And while others focus on fundamental issues related to specific approaches like chiropractic care or mindfulness or psychological interventions. Next slide. Just gives you the scope of one way of looking at the scope besides the amount of money invested. These trials are have now recruited just under 10,000 patients across all the trials at all of the sites that you see here. And I'm really delighted to say that we put a lot of effort into recruiting diverse samples, including in veteran populations, women, which are underrepresented typically in research in the VA and DoD, and also racial and ethnic and minoritized populations. Next slide. And then I want to end by putting this all in the context of a much broader investment of the NIH, DoD, and VA in pain management. I personally am involved and delighted to be involved in a few HEAL projects. These are the NIH Helping to End Addiction Long-Term Initiative, which itself is, as of July 2022, a $2 billion investment. Similarly, and I highlight two projects, one funded, one is a twinkle in our eye right now, that are all focused really on integrative models of care for people with chronic pain, but in these cases also opioid use disorder or opioid misuse. The VA is similarly prioritizing research at the pain and opioid space. And I'm delighted that recently VA central office leadership running the pain management program in VA central office have begun to fund partnered initiatives with health services researchers in the VA for a robust program evaluation surrounding major new pain management practice initiatives in the VA. And I think that's it. So thank you very much, Amy, and the leadership, and I look forward to a robust discussion moving forward.
Thank you, Bob. That was terrific. Well, now I will turn it over to Kate Nicholson.
Good morning, everyone. Next slide, please. As Amy said, I am Kate Nicholson. I'm the Executive Director of the National Pain Advocacy Center. Most of my career was spent in health-related rights at the U.S. Department of Justice, and now I am working primarily on policy related to pain, and I am a person with lived experience of pain. Next slide, please. So Amy touched on this for a moment, but briefly, pain by the numbers. Pain is our most prevalent chronic health condition. It is our most costly, and it is a condition of great consequence. 50 million Americans, or about 1 in 6, live in pain every day or nearly every day of their lives. 20 million, or nearly 20 million, have pain severe enough that it regularly prevents them from engaging in the most basic of life activities. Pain is the chief cause of long-term disability, both globally and in the US. And adjusted for inflation, we spend about $700 billion each year in lost productivity and healthcare costs related to pain. Next slide, please. So since we're talking about equitable access to whole person multimodal care, I wanted to begin by defining some terms. Disparities, first of all, are avoidable differences in health status among groups. Inequities are also avoidable, but they are unjust differences in health status. So the focus is more on unequal distribution of health resources based on structures and policies. Social determinants of health are the non-medical factors that affect health outcomes. And briefly, equity and equality are not the same thing. When we talk about health equity, we're really trying to create the optimum circumstances for everyone to thrive. And in order to do that, sometimes we have to treat people differently to get everyone to the same playing field. Next slide, please. So there is overwhelming data about inequities and disparities when it comes to pain. Significant disparities based on race, ethnicity, disability, gender, LGBTQIA status, limited English proficiency status. And these disparities exist throughout the healthcare ecosystem. They relate to insurance coverage, access to care, the quality of care people receive, health outcomes, mortality rates, and even inclusion in biomedical research. And just to highlight some of the studies, I'm mentioning a rule because it closes for comment today, and it's really well done, that HHS just put out on discrimination in healthcare. It's implementing Section 1557 of the Affordable Care Act. And it specifically highlights a number of the studies relating to bias in pain treatment on the basis of race and ethnicity, gender, and age. If you're curious about other data, you can also go to our website under Rights and Disparities, where we have a number of the studies. The HHS document also specifically talks about people with disabilities, which is, of course, really important in relation to pain, because as we mentioned, it is a chief cause of disability. People with disabilities face significant health barriers, including provider bias regarding how providers assess the quality of their lives, a tendency on the part of providers to substitute their judgments for patient views and preferences of their lives, and a much greater likelihood of being denied treatment. Next slide, please. So all of the major pain policies acknowledge these disparities, inequities, the presence of bias and discrimination, but they tend to approach the problem in terms of unitary categories. Next slide, please. And since we're talking about whole person health, another useful concept to bring up is intersectionality, because people don't come as, Black or older or disabled. We usually come in combination. So you might have a teenager who's Latinx, he's transgender and disabled, for example. The other thing that's important about the concept of intersectionality, and this is not my concept, it was developed by a law professor named Kimberly Crenshaw, is that when we focus on discrete categories, which science does and the law does too, like race, we tend to mythologize a universal experience for the group. And one of the consequences of that is that people who fall outside our stereotypes become invisible. So, for example, we know that pain disparately affects people as they age. We know there's significant bias in pain care based on race, and yet we have almost no research on pain in aging Black men because they don't fit within our presuppositions. Next slide, please. So this is something that has been addressed also by both Amy and by Bob Kearns, but we've sort of had a helter-skelter in our policy when it comes to pain. On the one hand, we've had almost no implementation, or very little, of the major pain policies like the National Pain Strategy, the IOM report, or the HHS Task Force report. Certainly threads have been implemented, but in terms of a complementary sort of and comprehensive implementation, it just hasn't happened. And then on the other hand, we've had very strict implementation of certain provisions in the CDC's guideline for prescribing opioids for chronic pain, That's something that Amy mentioned in the beginning. And the way in which it was implemented so strictly caused the CDC in 2019 to have to sort of come out and say that it was being misapplied. Next slide, please. And what are the consequences of that misapplication? Well, very briefly, it's hard to tell exactly how many people currently take opioids long-term for pain because prescribing has dropped. But studies suggest some 8 to 13 million Americans do. And here on the left, you can see a screenshot from a report on 2 studies suggesting that providers, particularly primary care providers, are just unwilling to take on a new patient who's been put on opioids long-term for care. So people are really being dropped in healthcare or facing significant barriers to access to care. Other studies have shown that 81% of providers are reluctant to treat such patients. Next slide, please. And we've also seen sort of problematic outcomes from opioid cessation practices, which were implemented as a patient safety measure. But what we're finding in a dozen or so studies that have come out in the last few years is that, in fact, it's often endangering patient safety. So we've seen an uptick in opioid discontinuation. It's often done abruptly. In some studies, it's shown to require emergency medical intervention. The discontinuation actually increases people's risk of overdose and suicide from 3 to 5-fold, in addition to destabilizing their health, mental health, and lives. And we've also found that it's not just opioid cessation, but even destabilizing dose that increases risks that can last for up to 2 years after dose is destabilized, risks that occur in patients with no known misuse or opioid use disorder, and risks that seem to occur regardless of the pace of the tapering. And since we're talking about equity, there are also studies showing a statistical correlation of these practices on the basis of race and gender. Next slide, please. In summary, it's important to take an intersectional approach when we're talking about whole person health and care. Access is essential. We cannot improve pain if people don't have regional or economic access to treatment. I'm someone who's been very privileged in my life, and yet many years I have spent more out of pocket on my healthcare than my housing. And finally, equity has to be a cornerstone. And one of the issues we're seeing is that preferencing treatments for pain that aren't well covered by payers or aren't available in certain regions may actually compound some of these existing disparities that we see. Thank you.
Thank you, Kate. That was terrific. Now, I'd like to turn it over to Dr. Ben Kliegler.
Sorry, it would help if I would unmute. Hi, everybody. Thank you, Amy, for pulling this together.
Of course.
I'm going to talk a little bit about what's going on with pain management in the VA and how it connects to issues around equity and access. And there's a lot to say about what's happening in the VA with whole health, so I'm going to talk fairly quickly. Next slide, please. Next, thanks. So for people who aren't aware, who are on the line, we've been presenting a lot, so people may know about this. We're moving forward this concept of whole health in the Veterans Health Administration. This is our definition, approach to healthcare that empowers and equips people to take charge of their health and well-being. The idea is not just what's the matter with you, but what matters to you. And the same idea is applying whether you're coming to the VA for pain management, for mental health issues, for routine health care, whatever it is you're coming for. The idea is it has to be about you, not about your disease or your condition. And so right off the bat, I think it's important to note, and I think the previous presenter was making this point in talking about intersectionality, you have to understand the person before you can produce a whole person and equitable kind of approach to pain management. You have to be willing to take a minute to understand the person and what are the forces, whether they are social determinants of health or whether they're internal forces about who the person is. You have to be able to engage with that in order to come up with the right kind of strategy. Next slide. Obviously, I could say a lot more about whole health, but it's built on kind of 3 pillars. One being the pathway, which is a peer-to-peer experience that veterans have with fellow veterans who have been trained as facilitators. And that's really where the idea is to start this conversation about who are you, what's important to you, what are your strengths, what are your challenges. Then as part of the well-being programs, VA is now covering 8 evidence-based complementary integrative health modalities, including acupuncture, massage, biofeedback, hypnotherapy, a number of others, and really has expanded the toolbox for pain management, I think very impressively, and in some ways much more than other healthcare systems. And then whole health clinical care, of course, we're continuing to provide disease management, pain care, mental health, rehab, all the stuff that VA provides. But ideally, all those encounters are encompassing this concept of you are at the center. What's important to you is kind of the governing principle, not just what I, as the clinician, think should happen to your disease. Next slide. And I want to just throw out there that when you talk about equity, that's an important concept. You know, we don't usually include this in our thinking about equity in terms of traditional areas of discrimination or prejudice or social determinants of health. But the lack of equity between physicians in particular, but clinicians in general and patients in general is an equity problem. In other words, we don't we deprive people of some of their power in the way we typically deliver healthcare, and I think that's something we need to deal with. And it's one of the things that really, to be honest, I love about the whole health approach is it just really dives right in, gets to the bottom of that and says, no, you know, the person is in charge. And we're actually moving away. I mean, my office is called the Office of Patient-Centered Care and Cultural Transformation. We are gradually trying to nudge towards person-centered care because obviously once someone is a patient, that equity problem is hard to avoid. So we've made great progress in the VA in terms of how VA thinks about its job. This is from the current strategic plan. And you can see they explicitly are talking about customizing whole health and services for the veterans, supporting their health and well-being, addressing what matters to them most. Next slide. In terms of a few of the outcomes that we're seeing, we are blessed with having access to a lot of data as these services expand and become accessible to more veterans. We're able to get more data. A lot of this was sparked by a piece of legislation called the Comprehensive Addiction and Recovery Act, which passed in 2016 and kind of went into implementation in 2017. This was a very large piece of legislation that mandated a lot of changes in pain care, mostly really for the better in VA and some in DoD. But among other things, it mandated increased access for veterans to complementary integrated health and whole health. So it pushed us to stand up 18 flagship sites around the country where there was dedicated funding, there was dedicated attention to building out this whole health approach. And I'm not going to go through all these results, it would take too long, but among other things, we did find that veterans who were using whole health on a regular basis were able to decrease their opioid dose much more substantially than veterans who weren't, 38% compared to 11%. We've also found recently that veterans who are using whole health have a decrease in the need for invasive spine procedures, things like epidural injections, back surgeries, stimulators over the subsequent 18 months. That's very encouraging. We're seeing also in general a greatly increased engagement with healthcare and healthcare decision-making in veterans who are choosing whole health. That is particularly evident in veterans with mental health diagnoses, where we have good evidence that they're more engaged in psychotherapy a year after starting whole health than they were before. And you can see we're seeing a number of different improvements in veterans with pain who use whole health services, quality of physical and mental health, overall engagement in life. Next slide. And we've had a lot published recently on this, so there's lots of stuff out there if you're interested. Thankfully, our pain colleagues in the VA are just so visionary and open-minded. They have really actively integrated the concept of whole health and of using the complementary integrated health modalities into what they call the stepped care model of pain management. So you can see the idea is you don't get to the pain clinic, the advanced diagnostics, invasive interventions until you've been through a number of steps. The first is actually self-management and self-care, where you can see things like meditation, relaxation, engagement in meaningful activities, etc. And at that level, and then at the level of pain management and primary care, you can see there's a lot of reference to the use of whole health and use of complementary integrative health. So why is this important? I think the big issue in terms of equity in our health systems generally is that access to a lot of these therapies that are known to be effective now for pain has really been limited to specific populations that can pay for that access either through insurance or out of pocket. In the VA, it's part of standard care, so it's there for everybody. Next slide. I think a really critical part of this and something we're really pushing forward, really with a lot of support from our new undersecretary and with a lot of widespread support across VA. You know, this idea that we can't be a system that really focuses on health and well-being, on what matters most to the veteran without really explicitly opening up the conversation about the structural determinants of health and then trying to put forward what options there are for addressing these things. If you have this great conversation about what matters most to you, but then you can't get there because you have food insecurity, you have a housing dilemma, you're subject to a racial or gender discrimination at work, we need to allow you to bring those questions out into the open, not that we then have the solution for all of them, but that at least we can start to talk about them with you. And you know, so many of these things are where people are stuck in their challenge with pain, that at least bring them out in the open is really important. And we're going to be doing a lot more work on this across VA, understanding how we can do universal screening for structural determinants of health, and then really be effective in sharing options for people who then experience some of those obstacles. Next slide. I think that may be all I had to say. So thank you for the opportunity.
Thank you, Ben. That was fantastic. Now I will turn it over to David Elton.
Thanks, Amy. Why don't
Sure.
you go to the next slide? And, start this just connecting to a couple items mentioned earlier with Robert, the National Pain Strategy. One of the elements was disparities. And so we'll share today some data on disparities in spine care across the country. And then, Kate appropriately called out intersectionality. And, in 5 minutes, this is going to be pretty high level. So important to be aware that there's really important nuances underneath these data we'll go through quickly. So as you can see here, this is data from a national zip code level look at spine care across the country. And I was fortunate to work with a couple of Optum Labs colleagues, Emily Zhang and Amy Okaya, on this work. So let's go to the next one. So a little bit about studies. This is out on medRxiv, so it's in preprint server to help us get information out quickly while the glacial peer review process plays out. So this study is available out in the public domain by preprint. Important nuances, this is a commercially insured population with low back or neck pain in the pre-COVID period. And so there's a reasonable hypothesis that when we move into, let's say, Medicaid or an uninsured population, some of the disparities we'll see could very well be amplified. So commercially insured population, relatively decent size, so 1.5 million episodes of a spine disorder, over 1 million individuals in about 30,000 zip codes. So it's not a US representative study, but it's a decent number of zip codes where we get a sense for the types of disparities that exist across the country. Looking at 17 types of healthcare providers and 14 types of services provided for spine disorders. So fairly detailed look at spine care. And then all of these analyses, we push down to a 5-digit zip code based on the individual's home address. And then we pull in data from the Census Bureau, the IRS, and the University of Wisconsin Neighborhood Atlas Area Deprivation Index, which is sort of a roll-up composite of poverty, education, housing. And so it's a real nice composite measure of some of the social determinants that are important. And let's go to the next one. So to get sort of framed on how we're looking at these data, let's just go right to the bottom of this slide to begin with. So we segmented all the zip codes by area deprivation index. So you can see right across the bottom, 75 to 100. The area deprivation index is a scale from 0 to 100. 75 to 100 would be high deprivation. 50 to 75, 25 to 50, and 0 to 25 ADI is how we segmented the zip codes. And then within each of those area deprivation segments, we looked at the population, race, ethnicity. And in this case, the measurement is 0 to 25% non-Hispanic white, 25 to 50 non-Hispanic white. So this framing set up sort of this mix of socioeconomic and population, race, ethnicity, and at the left, low income, high deprivation, non-white zip codes, and over to the right, affluent white zip codes. And now the purple bars just illustrate how the episodes, those 1.5 million episodes, shook out by these segments. And probably not a surprise given the population is that sort of the middle income, primarily white zip codes are where we saw most of the episodes. But the benefit of starting with 1.5 million episodes is even some of the the smaller volume episodes still have upwards of 10, 20, 30,000 cases of a spine disorder. So fairly decent sample to gain some insights into what's happening in these different zip codes. So let's go to the next one. So the first thing we were curious about is looking at the health system and looking at availability of types of different providers per 1,000 population in a zip code. And let's start in the lower left on this chart and let's go right to the bottom. So we segmented the types of providers into 4 groupings: primary care, non-prescriber, specialist, and emergency medicine urgent care. And primary care would be PCP, nurse practitioners, physician's assistants, doctors of osteopathy in a primary care setting. Non-prescribers are chiropractors, physical therapists, licensed acupuncturists, a range of medical specialists, ortho, PM&R, pain management, neurosurgical, and a variety of others, and then emergency medicine. And then for each of these groupings, you can see we have this ADI and percent non-Hispanic white segmentation. And a couple of things to call out. Lower left, primary care is the most available in every zip code type. However, in the 0 to 25% non-Hispanic white, so the non-white zip codes, clearly half as many primary care providers are available as in some of the other zip codes. And then the non-prescribers and specialists have this trend of increasing availability as population deprivation decreases. So as populations become more affluent, more non-prescribers are available and more specialists are available. And then the upper right, we just called out among the non-prescribers, looking at availability of chiropractors by this same zip code segmentation. And in number 2, the lowest availability, almost non-existent availability, were in zip codes high deprivation, non-white zip codes. Virtually no chiropractors available. And then in number 3, the greatest availability was in this sort of middle to higher income, primarily white zip codes, where we have the most abundant availability of chiropractors. And physical therapy looks the same, and acupuncturists are almost entirely an affluent Asian zip code phenomenon, probably not a surprise. Virtually no acupuncture available in the lower income, high deprivation, white, black zip codes. So this is kind of foundational to the whole disparities discussion that we'll get into. Is availability is obviously a key driver, and some of these zip codes just don't have availability to the recommended non-prescribing treatment options, as we'll see. So let's go to the next one, Amy. So there's a growing body of literature out there on how individuals engage the delivery system, who's the first provider an individual sees for a given type of healthcare condition, in this case, a spine disorder. So this looks at this same zip code segmentation across the bottom, and it looks at where do individuals with a spine disorder engage the delivery system by type or provider. In this case, we're looking at primary care, non-prescriber, chiro, we're calling out separately, specialist, and emergency urgent care. And the time we have, let's just focus on the extremes, right? So let's start on the left, number 4, individuals in low income, high deprivation zip codes, non-white population, overwhelmingly start with primary care. And nurse practitioners are actually disproportionately a higher percent in this segmentation. Fairly uncommon to start with a non-prescriber of any type. And if you get way into the nuances, you can see the emergency medicine, the dark gray line tends to be higher in these non-white zip codes. And then as we move to the right, the population becomes more affluent and becomes more white, and we get all the way over to number 5. For a spine disorder, individuals in an affluent white zip code are more likely to start with a non-prescriber, then primary care, then specialist, and emergency medicine, urgent care is pretty low. So very different ways that people engage a delivery system for a spine disorder, which builds off the previous slide where if non-prescribers are not available in the lower income non-white zip codes, it's pretty hard for individuals to start with an option that isn't available. And then that leads to what kind of services do people receive? And let's go to the next one. So in this case, we've sort of flipped the colors to looking at services individuals receive. And in this illustration here, first line services would be chiro manipulation, osteopathic manipulation, active care, manual therapy, acupuncture. Second line services would be things like prescription NSAIDs, skeletal muscle relaxants, radiography, MRI scans. And third line services would be things like prescription opiates, CT scans, spinal injections, spinal surgery. And so the same zip code segmentation across the bottom, now looking at what services do individuals receive for a spine disorder. And probably no surprise in number 6, low income non-white zip codes, more likely to receive a second line, actually receive third line services more often than guideline recommended first line services. And then as we move all the way over to number 7 on the right, affluent white zip codes, you're more likely to receive the guideline recommended first line service, then second line services, and finally a pretty low rate of exposure to third line services. And then in the upper right, we took this down a little bit deeper to look at 2 specific service types by this same zip code segmentation of ADI and percent non-Hispanic white. And in number 8, low income, high deprivation, non-white zip codes, individuals with a spine disorder are more likely to receive a prescription opioid than chiropractic manipulation at any time during an episode. And if you move all the way over to the right, affluent white zip codes, entirely the opposite story. We are far more likely to receive chiropractic manipulation and far less likely to receive a prescription opioid. So just very different treatment experiences set up by the types of providers that are available in given geographies, and therefore, types of providers individuals can access for their spine disorder. This really are just pictures of disparities in spine management in a commercially insured population. Now we begin to wonder, what does this look like for individuals that have, lesser or no coverage for these types of therapies? And why don't we go to the next one, Amy? So as we describe in the paper, and I think someone earlier might have been Kate, it's not a surprise that we see disparities, in this case in spine pain. And probably not a surprise as well that geographies with high deprivation, high percent non-white population have the lowest availability of the types of providers delivering guideline recommended non-pharma treatment options, resulting in greater use of primary care in the ED, which leads to greater use of primary pharmacological management, including greater prescription use of opiate prescription opiates. Something we didn't cover here, but we call out in the paper, and something we want to drill down deeper is the lower income non-white populations, almost 100% greater use of prescription NSAIDs, which if that were to play out over a relatively long period of time for individuals is associated with the potential for a host of undesirable consequences. So more work to do in this space for sure. And then the translation. So, what do you do about this? We don't need another guideline to recommend non-pharma treatment options. We need to really get into local healthcare ecosystems and understand how do we bring parties together to make these guideline recommended treatment options available. In this study, they're already covered. Relatively large networks of providers are available, but we just have this disparate availability in targeted local zip codes. And we sort of come back to what's the financial viability of solo or small practice models, particularly for these non-pharma options. And these are among the least diverse workforces in healthcare, chiro, PT, acupuncture. So, what are the barriers to a more diverse workforce, and a whole host of other factors to be solved for sure. And Amy, I think that is it for me. And I threw out some questions for the other panelists when we got there.
Yes. And
What's that?
Oh, and I'll say we'll get to those in Q&A. Those are great questions.
Yeah, and what's next for us is we pulled in Medicare Advantage. We moved it into the COVID period, which are some hypotheses that COVID might have amplified the lack of access to the non-prescribing options, pulled in some additional drug classes, pushed it down to a census block group level. And we're doing some innovative work here to pull in provider race ethnicity at the individual level to understand, this potential area of exploration around preferred concordance of providers of like race or ethnicity or gender. And so looking forward to digging into that. So thanks, Amy. Appreciate it. Look forward to the questions.
Yeah, absolutely. Thank you, Dave. That was really interesting. Okay, I'm going to turn it over to Denise, and we'll get to the Q&A when everyone's done. So Denise.
Thank you. Gosh, great
Yeah.
research, Dave. Thanks for sharing that. So Denise Giambalvo here, Director of Purchaser Strategies, the Washington Health Alliance. If we go to the next slide. So just want to acknowledge Arnold Ventures for funding the project that I'm about to speak about on acute low back pain. Next. Yeah, so just a little bit about the Washington Health Alliance. Our mission is to build collaboration between purchasers, providers, plans, and consumers in order to improve the health care system in Washington State. Our vision is quite ambitious, that physicians and hospitals will achieve top 10% performance in the nation in the delivery of high quality care. So we have much work ahead of us. We've been in existence for 18 years now, and continue to push this forward. Next slide. We are a 501c3. We started as a grassroots effort in 2005 and expanded to the entire state in 2013. We have 185 member organizations. So this is just a sample of a few of those. They include healthcare systems, hospitals, health plans, medical groups, and clinics, government agencies, startups, nonprofit groups, consumers, and they're all working together. We also manage a voluntary all payers claim database. We have about 35 organizations voluntarily submitting their data to that database, and representing almost 60% of the covered lives in Washington, and that's Medicaid and commercial data that we receive. Next slide, please. So this is showing some work that we did in phase 1 of our project. This is what led us to decide to focus on acute low back pain. So here, these are just some insights that was provided by the health waste calculator. So 8 purchaser members compared their results to the state average in Washington. These were all commercial plans, and purchasers we define as employers and union trusts as purchasers of healthcare. So you can note the commonality here between the purchasers. And when they saw the opportunity to address opioids and advanced imaging, and considering the impact MSK has kind of universally for all purchasers of healthcare across the country on their total cost of care, they decided that was the area that they wanted to really drill into. And so that led us to our next phase, which is the next slide, which was us focusing again on acute low back pain care. We created a pathway for all this. We started this in February. It took some time for us to reach agreement on this. Timely triage is an important area. You'll see, so green boxes all represent high value care. In the lower green box, one of the things you'll see in here is supported self-management. I'll put a link in here for people to be able to take a closer look at this. As you see each number, 1, 2, 3, 4, 5, there's another part to this care pathway that defines what's within those numbers. So another important piece is shared decision-making. So as we're talking about equity, definitely an important part to include when providing care. So for time, I'm not going to spend any more time on this care pathway, but want you to know that this is our level set. This is what we're using for the 31 organizations that participate in this collaborative. This is what they're using as their point of reference in terms of actions that they will take to advance high value care for acute low back pain, so thereby reducing the amount of low value care that's being delivered in Washington state. So next slide, in terms of equity, so everyone's required to put an equity lens on the work that they're doing. And so here are some examples of where they're taking action. So we have some employers that have implemented programs with a 0 copay and 24-hour access to triage. Providers are going back and looking at their educational materials and putting those into multiple languages. As we said, practicing shared decision-making, re-educating their providers on what shared decision-making looks like. We had one organization champion new legislation that would include coverage of chiropractic care for all adults in Washington, increased timely triage, and then retraining clinicians on how to provide supported self-management. So a lot of education taking place, not just with the patient or consumer, so before they become the patient, educating them on how on self-care, but also going back and educating the clinicians. Health plans, they're working to expand coverage for evidence-based alternative therapies. A lot of discussion on acupuncturists, how do providers find qualified acupuncturists in the state. And so we've actually provided them with a link to a web page where they can look for acupuncturists in their area, because we've had many providers comment on how they would like to refer their patients, they just don't know where to send them. And then deploying bilingual navigators who are focused largely on communities with limited English proficiency. And so we've seen great improvement there. And in fact, more providers even wanting to become a part of the network as a result of those navigators being in place and working with the patients. So I will now turn that over to Daniel, I believe. Yes, thank you.
Yes. Yeah, thank you, Denise. And just as before I turn it over to Daniel, I just want to again let everyone know Daniel is the final presenter before we start Q&A. And just keeping in mind what's exciting about all these presenters, you know, they're all coming at some similar information from a different stakeholder perspective. And we're excited to talk about that together during Q&A. So I will now turn it over to Daniel Blaney-Cohen from the American Medical Association.
Thanks, Amy. Hi, I work obviously at the AMA. I'm one of the attorneys in our state legislative group. I've been working on these issues for over a decade now. Next slide. That is the title of today's presentation, Advocating for Patients with Pain. I want to try to level set things here. Back one, please. Everybody on the webinar hopefully understands that the epidemic has continued to get worse. It has become worse primarily because of the presence of illicit fentanyl and fentanyl analogs in the nation's drug supply. If you look at the slide on the far left side, you see this was happening as far back as mid-2015. It's important to recognize this because most of the policy interventions, unfortunately, have not focused on integrative pain care, but they've been focused on restricting access to opioid analgesics. Next slide. And that really came to a head, as few have mentioned, the 2016 CDC opioid prescribing guideline for chronic pain. And it's important the details that guideline restricted opioid prescribing to 3 to 7 days and less than 90 daily morphine milligram equivalent. The AMA back in 2015, 2016 strongly advised against this because we were concerned that states, payers, pharmacy chains, and others would use that as a hard threshold policy, and that's exactly what they have done since 2016. And unfortunately, the policy intervention to restrict access to legitimate medication for patients' pain has not had the intended effect of reducing overdose deaths. Policymakers said if we just restrict access to opioid analgesics, it will end the epidemic, and that has not happened over the last 10 years. Opioid prescriptions have decreased by more than 46%, and strength of those prescriptions have decreased by more than 57%. Next slide, please. The overwhelming interest here is that we agree with CDC, and this is the 2022 proposed change that CDC is making. It has not been finalized yet, but this is the proposed change. They admitted that they were wrong in 2019, and in 2022 they put that into additional print. But the key here is not just, it's fine, it's great that people admit that they made a mistake, but it has to be put into play. And by putting this into play means that, and we'll get into this later, but all policy needs to change. States that had enacted laws based on that guideline need to be removed, or there need to be laws such as one that was implemented and enacted in Minnesota earlier this year that provide some protections for patients who do benefit from opioid analgesics. And there are hundreds of thousands of patients, if not more, who do benefit. But if states and payers and pharmacy chains and others don't change their policies, we should not expect any change in improved outcomes for patients with pain who rely on opioid analgesics. Next slide, please. The other main policy interventions toward ending the epidemic with respect to patients with pain has been to mandate the use of state prescription drug monitoring programs. The AMA strongly supports the use of PDMPs as one of the clinical tools to help identify what's going on in a patient's prescribing history, and also for the prescriber to take a broad look at what their own prescribing practices may be. And policymakers said, if we only mandate the use of PDMPs, the epidemic will decrease. Last year, there were more than 1.1 billion uses of state PDMPs, and yet more people continue to die. And one of the reasons they continue to die is that the drug supply has changed to illicit sources, including illicit fentanyl, also methamphetamine and cocaine that's throughout the drug supply. But also the epidemic, in large part has never been about opioid prescribing. Yes, there were illegal actions. There were people who ran pill mills, and we're glad those have been shut down. But as a result of the 2016 guideline and the policies that states, payers, and pharmacy chains have implemented as a result, that has largely restricted access to legitimate medication. And there are severe consequences. There have been severe consequences for patients with pain. And also there has been, as we've heard a little bit here today, there really hasn't been any meaningful increase in access to non-opioid pain care. And I'll get into some of the reasons in just a minute. Next slide, please. So what has happened? As a result of that 2016 guideline, the pressure to terminate and taper opioid therapy for patients with pain, whether they were stable on a long-term dose or not, has been intense. The pressure has not only been on physicians and other prescribers, but the pressure has been on patients. Patients have been flat out discontinued. The VA had a policy to do something like that. They've taken a look at it. They've stepped back from that. Patients have died by suicide because of these therapies. Tens of thousands or more patients just continue to suffer from non-opioid, from this focus on, well, if we have to terminate opioid therapy because opioid therapy is bad, or if it's over 90, then we're obviously bad. And physicians face incredible scrutiny. They don't want to end up on the list. Oh, we're prescribing more than 90, so let's taper the patient down because of concern from law enforcement and other professional scrutiny. The increased stigma and scrutiny when the opioid therapy is indicated, primarily at the pharmacy counter, but in many other places as well, that has continued. And again, there really hasn't been any meaningful increase in access to non-opioid therapies. It's fascinating to me that if networks are inadequate for providers of non-opioid and non-pharmacologic care, then that's up to the payer to increase access in those networks. It's up to state regulators to enforce network adequacy laws. If networks are inadequate, this is no surprise to any of us, right? If networks are inadequate, there are immediate steps that can be taken. Increase the contract rates to attract more providers into the network. This is really a no-brainer. And that's just part of the continued challenges in access to integrative multimodal pain care and multidisciplinary pain care. If we want to increase access, then we have to reduce cost sharing for patients. We have to identify that social determinants of health are a continued problem in those inequities in pain care. And most importantly, we need to do this because since 2016, there's increased frustration, pain, and suffering. And from the AMA's perspective, if policies aren't improving access to care and they aren't improving patient outcomes, then those policies need to be meaningfully addressed. Next slide, please. So we all have a role to play. This is certainly a non-exclusive list. And the slides are available to everybody, so I won't read through the slides that everybody can read. But the point is here, there have been, and as you've seen today, there have been many studies. There are so many studies, but the prime policy actions that have happened, have been to restrict opioid prescribing and to mandate PDMPs. Congratulations in Washington. That's fantastic that there have been some actions, and other states. Like I mentioned, Minnesota has a new law that hopefully will help Oklahoma and New Hampshire have laws that are designed to help patients with pain. But those are only like 3 states out of 50 plus the District of Columbia. There's a tremendous amount more work that needs to be done. We all need to work in this together and to identify what's harming patients. And if there's an opportunity to take action, that absolutely has to be taken action at the physician, payer, employer, and policy level. Next slide, please. Again, these are just a couple of resources from the AMA commercial here. And you can get those when you get the slides. And I'll finish up with the last slide, which I think brings us into the questions. Thanks, Amy.
Thank you, Daniel. I can always count on you to kick us off into good provocative thoughts. So, all right. So Bob, if you want to come on too, we are now going to move into panel discussion, and we're all friends here, so we can really kind of address some different questions. I believe the Q&A has been answered. I was not able to follow while I was sharing slides, but is there a Q&A question that was answered that should be discussed now?
There was one good one, Amy, which was someone asked the question of whether having students from complementary medicine schools, staff, integrative pain clinics was a viable option in places where there isn't good coverage. And I just jumped right in and answered yes, because that's been something I have done in various places, but really hundreds of us have done in various places, up to and including there was a very large and busy free clinic at Venice Family Clinic in LA for a long time that was entirely staffed by chiropractic students, acupuncture students, massage students. And I believe it's moved on now, but it was wonderful and treated thousands of people. And I think lots and lots of places, in my group in the Bronx, we published a study of bringing acupuncture students into community health center setting to treat patients with pain. And we found that was an effective strategy for reducing pain in a underserved population. So I think whoever asked that question, if you have that as an option, you should feel encouraged and you should go do it. There are challenges, but the challenges are totally surmountable. And while we work on getting bigger coverage and adequate networks, I think that is it's kind of a win-win. Students need places to practice, and a lot of our patients need practitioners. So that was the one I wanted to share. Thanks.
Yeah, thank you, Ben. I wanted also, I think Daniel kind of ended with some call outs for some action opportunities or thoughts, and I wanted to see if anyone wanted to respond to some of the things that Daniel mentioned in his slides.
Yeah, I can jump on one. We as a commercial payer dropped patient out-of-pocket costs for individuals with back pain accessing chiro and PT. Did that in 2019. And what I will say is that had no impact on access, no measurable. So even the elimination of out-of-pocket costs didn't move the needle materially, number one. Number two, network, we agree. We've got, what's the right number? It's hard to know. I think we have 150,000 chiro, PT, and acupuncturists across the country, roughly 40,000 chiro, 100,000 PT, 10,000 acupuncturists. We get, I think, 500 requests to join a month. Nobody leaves. And so network's an interesting discussion. I think all providers would say they're under reimbursed. The question I'd have for Daniel is the AMA's position on chiro, PT, and acupuncture one of supporting direct access by consumers without a medical referral? So consumers being able to directly access chiro, PT, and acupuncture. Because that physician referral requirement introduces delays. We know that there's very few patients that, when starting with an MD, end up with one of those therapists. So direct access seems to be super important. And wondering if the AMA is supportive of that.
Yeah, thanks, David. I mean, we support physician-led team-based care. And, there may be states may have taken, different avenues for that. Some allow direct access, some don't allow direct access. We fully support, physician-led team-based care. So, when it comes to working together, I think one of the things that might help, Amy mentioned at the very beginning, some new codes to support bundled payment in Medicare. And, and that's a proposed policy, if that goes through, I mean, it's the kind of thing that, allowing for that. And I think Bob had something, earlier about incentives. If all payers, embrace the idea that patients with pain sometimes need more complex services. And in a capitated environment or an environment where contracted rates are low, particularly in family practice, that might be difficult. So, being allowed, payment is not an abstract concept. And so, paying fairly and paying adequately, is an important part of the equation. And at the same time, chiropractic, PT, acupuncture, even seeing the doctor, sometimes these are what some people call middle-class solutions, right? Because you got to take time off work. Sometimes there is going to be cost sharing. Sometimes, you don't get to go during 9 to 5. And so it's just, there are other reasons people can't access those services. So again, we definitely all have to work together. And yes, we absolutely need physician-led team-based care.
I think that's a problem to limit coordination of care to a physician. I think there are many barriers to that idea. First of all, there are other providers that are competent to coordinate care. It places biological, increasingly people in the pain field are talking about flipping the biopsychosocial model on its heels, turn it around to being a psychobiological model. The primacy of medicine and a medical approach in this field, I think, has continued to cause us problems. So I think we should be exploring alternative models of care coordination beyond physician-led teams. And so I'm a proponent of that. I think the other thing that I wanted to react to, Daniel, to your presentation, and I think broadly, is the growing evidence of beyond issues related to addiction and opioid overdose, and beyond opioids. There's growing, as people are studying potential adverse effects of long-term use of opioids, but also NSAIDs, whatever it is, gabapentinoids. The evidence keeps mounting about potential harms that I don't think most providers are even really all that knowledgeable about, let alone the patients. So I think there's a real need to focus in, I am calling out medications, but I think shared decision-making about use of medications in the context of managing chronic pain in particular, but really across the board. And importantly, other co-occurring conditions, which I tried to emphasize. I think, we need to show greater respect for our patients and their families by being more open to sharing information that is now available about potential harms. The last thing I'll say, that I put in the chat quite a bit, is I think it's workforce development. I think, and part of that is the financial incentives. How do we, change our incentives to encourage more psychologists to get interested in pain and pain management, or, get acupuncturists and so forth. I think we all have a shared responsibility to work within our professional organizations to try to encourage continuing education, but also education and training at the graduate or pre-graduate level, really regardless of, there's been a big focus on medicine I'm very proud of the efforts we've done to shape up the curriculum here at Yale in the School of Medicine. I think nursing is on top of this. Psychology, I know, is trying to get on top of this, but we have a long way to go to fill the gaps just in terms of the workforce. So we can't address issues of access without taking responsibility for that.
Thanks, Bob. Ben?
Yes, I just want to jump in. First of all, not to Daniel, I'm a physician too, and I just want to say, I hope you're hearing this in the spirit of collaboration and advancing the field. I think you're doing great things at AMA. I did want to raise, and that wasn't what I wanted to say. I just wanted to share that. I do wonder regarding AMA though, is like, and you could jump on this after, but somebody did put in the chat, what about nurse practitioner led care teams? Because I think as we go forward in the long run, there's kind of an intermediate space where maybe there are non-physician providers that can provide the same kind of coordination oversight. But that's not even what I wanted to say. What I wanted to say is a little bit further out of the box, which is when you look at that data about overdose, doubling since 2015, it cries out to ask the question, what is wrong in the country? What is wrong with this country? And yes, we could say some of it is cheap fentanyl from China or whatever it is we want to say. But what's really wrong is this incredible epidemic of loneliness and hopelessness that's happening in the United States. And I think it's on everybody. I'm sure everybody here is doing their part with this already, but I think we actually really need an explicit public health campaign around helping people connect with each other again, because ultimately, that's the biggest driver of overdose. And if you put up the numbers on suicide, they're just as shocking as the overdose numbers. And that's not just about pain, and it's not just about opioids. It's not just about access. It's about despair. And despair, we have the tools, to help mitigate despair. We're just not using them. So I just want to throw that out there. I know it's a little off topic.
Yeah.
Thank you.
Thank you, Ben. No, I think that's important to think about. And Kate, I'm going to call on you to, I know you have something you want to say, and I also am hoping that you might just weigh in too on what you're hearing from different patient groups, as it relates to this, as we're talking about patient-centered, really person-centered, whole person care, just to not lose sight of kind of what you're hearing as well.
Sure, be my pleasure. So I did want to respond just quickly to what Bob said, because while I agree we need to expand access to all kinds of pain treatments, I don't want to overly disparage already sort of stigmatized use of medication, because sometimes it is necessary. I'm someone who, couldn't sit, stand, or walk for many years after a surgical injury to part of my spinal cord, and had interdisciplinary care for 3 years and 2 of the best pain clinics in the country at the time. This was in the 90s, and did use opioids for a time. Luckily, I later had surgeries where they were able to really fix some of the problems, and I don't need medication anymore. But there are a lot of people in my group who still do, who have pretty serious conditions and disabilities. So I think everything is a cost-benefit analysis when it's a treatment modality. We can't just say, all we look at are the harms, because there are also potential benefits. That doesn't mean that we don't need to expand access to and provide, access for other folks. The thing that I hear about most is still people being dropped in care, stigmatized, and providers not really wanting to treat people with chronic pain. I think, it has been, a significant problem, and there are studies that show it, but I also hear it a lot in pain groups and among patients, in unsolicited emails and phone calls I get almost every day. So we seized on a one-size-fits-all solution, and now we're trying to take that one-size-fits-all solution away when we have a lot of people who are put on the medication, and we're just not looking at patient needs in a complex and nuanced way, and in an equitable way.
Yeah.
And I agree about despair and connection. And I also, think we have a really dangerous street supply, and we need to employ more harm reduction techniques as well. But I absolutely agree about, some of the deeper social problems.
Right. Thank you, Kate. And I want to give Daniel a chance to respond to what was asked to him, but I see that Denise, you have your hand raised. So I want to give Denise the chance to talk. You haven't talked yet, and then we'll go to Daniel to respond to what we were discussing. Denise.
Thank you, Amy. I'll try to be brief with the few points that I want to make. So to Daniel's point, I just want to emphasize because he made a good point in terms of what the different stakeholders have, like their responsibilities. So in our collaborative, we do have the health plans, the employers and union trusts, so purchasers, and the providers all at the table working together. I didn't place great emphasis on that earlier, and I just wanted to make sure everyone understands that. In the care pathway, to the point of the patient gets to choose where they start their care. We didn't dictate where that triage takes place, to acknowledge that they may start with a chiropractor, they may start somewhere else. Primary care, they really don't have the time to, as it relates for us to acute low back pain, they really don't have the time that is needed to be able to go through the process with the patient to direct them to the best treatment pathway. So that's something that we definitely need to address. It's much easier for them to prescribe some form of prescription along with some imaging. And then, so APTA, so the American Physical Therapy Association in Washington, they are looking to provide incentives for BIPOC primary physicians to educate them and get more involved in treatment. And then also the Chiropractors Association in Washington, they are going to survey all the chiropractors in Washington to identify who is BIPOC. And then also they're starting to have discussion on how do they attract more BIPOC people into chiropractic. So
terrific. Thank you, Denise. What I'd like to do, I know we're already running out of time. I'm going to give it to Daniel, but after Daniel, if you could just take a minute, and just try to be concise, because I'm sure you have a lot more to say than that. But and then I would like to just give everybody, after Daniel's done, I'd like to just go one by one. And so you can be thinking about this too, but to address the focus of connecting the dots and what collaborative opportunities that you see that could help advance access to equitable multimodal care. And we'll go through, give everyone a chance to say, one or two or three quick things, but just in about 20 seconds to each of you. So Daniel, go ahead.
Thanks, Amy. I think shared decision-making is essential, obviously. And we want to return care to individualized patient care decisions between the patient, and his or her physician. I'd encourage us all to take a look at, what gets in the way of that. And not everybody has access to the same things. Those inequities, David highlighted some of the inequities with respect to race and income. There are also, massive inequities that that women face because they're somehow supposed to be tougher, particularly pregnant people, who, when they're facing pain, that somehow their pain shouldn't be treated as comprehensively as non-pregnant people, and that's just unacceptable. Those are the types of things and myths. Among the myth that opioid analgesic helps tens of thousands, hundreds of thousands of people in this country, and to suggest that it doesn't perpetuates the myth that patients with pain don't deserve to be listened to. And that's just something that has to be directly confronted at the individual level. And those policies that get in the way of that should be revised and rescinded. So if the focus is put back on what does the individual patient need, then we'll start to restore some of that balance. One size fits all solutions haven't worked, they're not going to work. And we want to be able to respect the needs of the patient and the physician and other healthcare professionals who are treating that patient.
Thank you, Daniel. So now we're going to do just a quick round robin. Again, so AACIPM, we really like to connect the dots. I like that term. And what can we do with different stakeholders here? Any thoughts of what you would like to throw out to challenge any of us to think about connecting more dots to advance equitable, whole person, multimodal pain care? So let me start with Dave.
I think, it's been mentioned a number of times, Daniel, most recently, I think we put the patient in the middle. That's usually a good place to start. And I think the dots that are available are so variable based on the zip code we find that individual in. And so how do we connect the dots in a meaningful way in each zip code around the country seems to be more productive. It's almost a bottom up, very granular approach than try to come off, down from on high with some big policy effort. Put the patient in the middle, work with the resources you have in a local community.
Love it. Thanks. Denise?
Yeah, and I'm thinking of it in terms of how do we define preventive care and how does that relate back to the plan design? So with all the high deductible health plans that are out there, the barriers that creates by the member having to reach deductible before they can receive certain care.
Thank you. Kate?
Thanks, Amy. I still feel like a lot of complementary and integrative care is just not accessible to most patients. I pretty much only use that now, but I pay out of pocket for virtually all of it and I'm able to. That's just not the case for a lot of people that I talk to. I'm a big believer in preventive treatment and across the spectrum, not just from acute to chronic, but a chronic to intractable as well. And I think there are some exciting things, at least in terms of patient representation that have been happening lately. I mean, we're involved with an initiative at NIH and the EU to sort of vote on pain domains. We're being asked as people with lived experience to comment on new diversity guidelines for publications, even on pain research. The National Academy of Medicine's projects and the Opioid Collaborative has had us involved in their chronic pain journey map. And so I think there is a lot of opportunity for patient participation across the healthcare ecosystem, and that's starting to happen. It still isn't happening enough with the diversity of patients I'd like to see. And I do find that in a lot of these meetings, they still want somebody like me who has an education that they recognize and not some of the other people I want to put into the group who have more diverse backgrounds, but we're working on that.
Thank you, Kate. That's exciting. Ben? Oh, you're on mute.
Having a lot of trouble with my mute button today. Yeah, without wanting to get super corny, I think I'm just going to go back to what David said in the sense of it. And I know this sounds facile. I don't mean it to sound that way, but if you start with the person, then you're not only starting with their pain, but you're starting with the idea of making a connection with that person and what's important. And just to me, that's the root of every problem we have in healthcare is our failure to do that. So I think that's a message that just needs to get out there through every possible channel.
Thank you. That's great. Daniel?
I think policymakers have a real opportunity here. We know the policies that have hurt people, and we know the policies that limit access to care, all the different care options that have been mentioned here in the chat and in the Q&A. Policymakers have an opportunity to directly remove and rescind those policies that have hurt patients with pain, and they have an opportunity to require pharmacies, payers, and others to implement those policies that would increase access for a wide variety of pain care options for patients with pain. If policymakers don't take, because it's shown that that payers and pharmacy chains in particular are not going to change what they're doing without being required to do that by policymakers. If policymakers don't take those opportunities, I don't think we should be surprised that there aren't improvements for patients with pain.
Thank you. And Bob.
So just the risk of stepping out in a different direction, I have been impressed with other countries' public health messaging campaigns around pain. I think of Australia and their "Don't Take Back Pain Lying Down" or something like that campaign. I'd love to see groups like this continue to advocate on the multiple fronts. This is a multi-pronged problem. So, all that being said, I think one additional possibility is potentially partnering with CDC and maybe other government agencies, but I think CDC is ripe around finding the money and will to support a public health messaging campaign in support of the kinds of ideas that we're all talking about today.
Thank you. I love that that everyone has a different answer, which I think gives us a lot of opportunities to really think about this. I'm just sorry, I am having trouble here with trying to move this. I know you can't see this very well here, but in the spirit of time, I'm going to wrap this up, but I think this was such an excellent webinar. I just want to thank each and every one of you, all of the panelists today, for your time and your thoughtfulness and allowing the conversation to get real. And because this is hard, and we all know this is not simple, and complex problems don't change with simple solutions. And so we will share this information and get back to everyone. We'll be doing additional webinars. Please share feedback. If you just want to take a moment and shoot us an email, let us know, because we really are looking for more feedback around what would be helpful for you to make changes in your own world. The slides will be available at this link, and I thank everyone for your time today, and wish everyone a beautiful rest of your day. Thanks so much. Thanks,
Thank you, Amy.
Thank you, Amy.
Yeah, thank you.